Hello and welcome to the SSMR SMRU Male Infertility Lecture Educational Series. This webinar focuses on the new AUA-ASRM Male Infertility Guidelines. Dr. Matthew Coward will be moderating this webinar. Dr. Coward is a co-creator of the SMILES webinar series. He is Associate Professor of Urology at the UNC School of Medicine, Director of Male Reproductive Medicine and Surgery at UNC Fertility, and Program Director for the Andrology Fellowship Training Program at UNC. He serves on the board of directors of ASRM's Society for Male Reproduction and Urology and the Society for the Study of Male Reproduction. Before we begin, please note this webinar was developed by the Society for Male Reproduction and Urology, the Society for the Study of Male Reproduction, and American Society for Reproductive Medicine as an educational resource in service to its members and other practicing clinicians. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. All attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. I will now turn over this presentation to Dr. Coward to introduce today's speakers.
Hi, everyone. My name is Matt Coward from University of North Carolina, and I'll be the moderator for today's webinar. We started SMILES at the beginning of the pandemic as an educational program during the clinical shutdown, and it's now a webinar supported by the ASRM in a way I never imagined would be possible. I'd like to thank Dr. Aziz at the ASRM and Dr. Stan Honig, Natan Barchama, and Philip Lee at the SMRU who've supported the effort tremendously. It also wouldn't be possible without the help of Dr. David Shen and Dan Williams, who together with me make up the education task force from the SSMR and SMRU. We'd like to extend our gratitude to the SSMR and SMRU, as well as all of the speakers who have helped us along the way to make this possible. Today's webinar is a very special session where we will have Dr. Schlegel and Dr. Tanrikut present the exciting new guidelines on the evaluation and treatment of male infertility. Next slide. Here are all of our disclosures. Next slide. The new male infertility guidelines were jointly created by the AUA and the ASRM and were very recently released in December 2020 and jointly published in FNS and Journal of Urology. The guidelines are published in two parts. Part one focuses on the evaluation of the infertile male, and part two outlines the appropriate management. You'll see a link on your screen where you should be able to download the two documents, which I'd encourage you to go ahead and do now in case you want to follow along during the presentation or reference later. For the webinar format, first we'll have Dr. Schlegel give an introduction on the evidence-based process for establishing the guidelines. And then we'll have Dr. Tanrikut speak about the male infertility evaluation, which is guidelines part one. Finally, we'll return to Dr. Schlegel, who will present on the management of male infertility, which is part two of the guidelines. And then Dr. Schlegel will conclude with a brief summary and key updates. At the end of the presentation, we should have 10 or 15 minutes for questions. Please submit the questions through the webinar, and I'll ask the speakers as many of the questions as possible. Next slide. All right, without further ado, I'm excited to introduce today's speakers. Dr. Cori Tanrikut is Clinical Professor of Urology at Georgetown University School of Medicine and Regional Director of Reproductive Urology at Shady Grove Fertility. She served as a committee member on the AUA-ASRM Male Infertility Guideline Panel and is past president of the Society for Male Reproduction and Urology. Dr. Peter Schlegel is the James J. Colt Professor of Urology and Reproductive Medicine at Weill Cornell Medical College and chair of the recent joint AUA-ASRM Guideline Panel. He is past president of the Society for Male Reproduction and Urology, the Society for Reproductive Surgeons, the Society for the Study of Male Reproduction, and most recently of the ASRM. It's my pleasure to turn over the program to Dr. Schlegel.
What about the guideline process? This guideline was developed with a focus on an evidence base. So the analysis that was done was based on evidence that exists in published literature. It was done by the Emergency Care Research Institute, or ECRI, which is an evidence-based practice center team, and involved a search of publications on PubMed, Embase, and Medline between January of 2000 and May of 2019, with additional selected articles that were identified by the members of this committee. It is a PICO-based question format where you look at patient, intervention, comparator, and outcome. So for example, you may look at a patient with a normal testosterone and idiopathic infertility, with an intervention being treatment with a SERM, such as clomiphene citrate, comparator being placebo or no treatment, and outcome being, for example, pregnancy. So the questions that were analyzed by the ECRI team had that sort of format. The evidence that was generated from those searches was rated A, B, C, and D in standard AUA format, and then additional statements that don't have evidence behind them were presented as either clinical principles, meaning approaches that are widely accepted in clinical practice, or expert opinion, where evidence was not adequate, but the pooled concepts from the entire guideline panel supported those specific statements. Originally, I was asked to chair the AUA guideline panel on male infertility. I asked that this be a joint activity, and so there were 5 ASRM members, 5 AUA members, as well as the ECRI's representatives. As Dr. Coward just stated, on the next slide, we have all of the members. Sarah, if we can go to the next slide, of this committee. I chaired the committee, Mark Sigmund co-chaired it. We had a patient representative, andrologists, endocrinologists, urologists, all working together. Reproductive endocrinology was represented as well. Next slide. As Dr. Coward said, these AUA-ASRM guidelines were released in December 2020 and published in both Fertility and Sterility and Journal of Urology. They focus particularly on counseling for males in an infertile couple, the relationship of infertility to other diseases, and specific effects of male infertility causes that Dr. Tanrikut's going to talk about in more detail. She's going to overview the male evaluation, including male evaluation for failed IVF or recurrent pregnancy loss, which has a very parallel evaluation recommended. And then I will talk more about treatment as well as chemotherapy or radiation effects. Let me now turn things over to Dr. Tanrikut.
Thank you, Dr. Schlegel. It's a pleasure to be here. I'd like to thank Dr. Coward and the ASRM for inviting me to join today's discussion of the Guideline Committee statements regarding the infertile male evaluation. I really think that these guidelines are of particular importance because they highlight the increasing recognition in the past decade that male infertility is more than just a medical condition to treat so that a couple can have children. Male infertility may reflect underlying diseases that warrant further investigation or treatment. There are several objectives of assessing men with infertility, including the identification of correctable issues in an effort to optimize the reproductive health of the male partner. This in turn may help improve the couple's chances of conceiving on their own or using less aggressive fertility treatment approaches. We may diagnose conditions that are not correctable, but which do allow for pursuing ARTs using the male partner's sperm, or if it's determined that that's not feasible, educating the couple regarding alternative options for family building, including donor sperm or adoption. We also aim to identify health-threatening conditions that may be associated with male factor infertility. And finally, evaluation of the infertile male may detect genetic abnormalities that can impact the health of the male partner himself or his offspring, with counseling as appropriate. Next slide, please. Let's start with the 4 guideline statements regarding approaching assessment of the infertile male. Next slide. At the onset of a couple's infertility evaluation, both male and female partner should undergo concurrent assessment. Now, for the male partner, this should include a reproductive history and at least 1 semen analysis as a basic diagnostic test. Some important aspects of the male history are included in Appendix 1 in Section 1 of the document, so you can take a look at that if you've downloaded already. This includes, among other items, whether the patient has conceived previously, and if so, what the outcomes of those conceptions were. Assessment of sexual dysfunction that may impair conception efforts. A history of cryptorchidism, which is associated with both increased risk for infertility and testicular cancer. Prior groin or scrotal surgeries or trauma, or family history of infertility. Obtaining a history also affords an opportunity to review any medications that may impact testicular function, such as exogenous testosterone use, which is quite common these days, or to identify lifestyle choices that could be impairing sperm quality. With respect to the semen analysis, this should be performed in concordance with WHO standards. It's important to understand that when interpreting a semen analysis, the semen parameters alone cannot be used to predict a man's fertility potential, of course, aside from those men who are azospermic. Abnormalities that we see in semen parameters do, however, guide our diagnostic approach. Men with 1 or more abnormal semen parameters or with presumed male infertility based on history should be evaluated by a male reproductive expert in order to undergo a complete history and physical examination, and other appropriate testing is indicated by the history and exam findings. A comprehensive evaluation with an expert such as this not only aims to enhance a couple's reproductive efforts and outcomes, but it also ensures attention to the man's overall health and future health. Now, the final statement on this slide is key, and I think it really warrants special emphasis and consideration, and we'll come back to this in later slides. In couples with failed ART cycles or recurrent pregnancy loss, evaluation of the male should be considered. This highlights the relevance of sperm-related components to embryo quality and maintenance of pregnancy. Testing to consider in the setting of either failed ARTs or recurrent miscarriages would include a karyotype and assessment of sperm DNA fragmentation. Next slide, please. We'll move on to the 4 guideline statements related to lifestyle and general health. Next slide. Clinicians should counsel infertile men or men with abnormal semen parameters of the health risks associated with abnormal sperm production. Up to 6% of men have undiagnosed medical diseases at the time of their infertility evaluation. Multiple studies for this particular guideline found that men with abnormal semen parameters had higher rates of testicular cancer and higher mortality rates. These findings mean that a diagnosis of male infertility has implication for that man's life going forward. And I do believe that as we learn more about this aspect of how male infertility and men's general health intertwine, it's plausible that we may specify screening or future follow-up for particular diseases that are associated with male infertility. Infertile men with specific identifiable causes of male infertility should be informed of relevant associated health conditions. For example, those men diagnosed with previously unidentified Klinefelter syndrome should be counseled regarding spermatogenic dysfunction, which is what brought them to the point of diagnosis, but also impaired testosterone production, gynecomastia, risk for breast cancer, autoimmune disorders, and osteoporosis. Another example would be men diagnosed with testosterone deficiency during the course of their evaluation for impaired sperm production. Testosterone deficiency itself is associated with diabetes, hypertension, and cardiovascular disease, among other issues. Clinicians should advise couples with advanced paternal age that there is an increased risk of adverse health outcomes for their offspring. This is a big one in this guideline. When it comes to semen parameters and advanced paternal age, nearly all parameters demonstrated an age-associated decline. So that includes ejaculatory volume, total sperm count, progressive motility, percent normal morphology. The only parameter that did not demonstrate a change was sperm concentration. With respect to offspring, advanced paternal age increases sperm aneuploidy, structural chromosomal abnormalities, birth defects, and genetically mediated conditions such as schizophrenia and autism. A controversial point about these data is that there is no defined age threshold for advanced paternal age, but in the majority of studies assessed, greater than 40 years was used as the cutoff, and this certainly has implications for many of the patients coming into our centers. Clinicians may discuss risk factors related to lifestyle that may be associated with male infertility. For example, obesity, poor diet, and smoking. These were all associated with some degree of impairment of fertility. I'd like to point out that Table 6 in the guideline, which didn't translate well to a slide, so I didn't include it here, provides a useful summary regarding lifestyle-related factors. Now, the data are somewhat limited in terms of identifying favorable lifestyle interventions that will clearly advance male infertility, which certainly would be a fruitful focus for future research. Next slide, please. The next several slides summarize the guideline statements regarding evaluation and diagnosis. Next slide. The results from a semen analysis should be used to guide management of the patient. In general, results are of greatest clinical significance when multiple abnormalities are present, meaning that a man who has oligoasthenoteratospermia, for example, has a higher risk for infertility than a man with isolated asthenospermia. Clinicians should obtain hormonal evaluation, including FSH and testosterone, for infertile men with impaired libido, erectile dysfunction, oligospermia or azospermia, atrophic testes, or evidence of hormonal abnormality on physical evaluation. The biggest take-home message for this guideline statement is that endocrine evaluation is not a primary or standard test in the evaluation of the infertile male, nor is it of utility in men with isolated asthenospermia or teratospermia. Blood work for testosterone levels should be drawn in the morning, as levels peak in the morning and decline during the course of the afternoon. If that initial serum testosterone level is low, then additional hormone testing should be obtained, including a confirmatory total testosterone, as well as free testosterone, LH, prolactin, and estradiol. FSH, as I think most in this audience are aware, stimulates spermatogenesis. And in the setting of normal sperm production, negative feedback maintains FSH in a normal range. With primary spermatogenic dysfunction, this negative feedback is not present, and the pituitary gland compensates and produces more FSH. When interpreting FSH levels in men, although the upper limit of normal for a lab report may be as high as 20, it's critically important to understand that from a clinical perspective, anything higher than 7.6 is consistent with primary spermatogenic failure. So I'll say that again, an FSH higher than 7.6 is consistent with primary hypogonadism. Azospermic men should be initially evaluated with semen volume, physical exam, and FSH levels to differentiate genital tract obstruction from impaired sperm production. These findings taken together can provide valuable insight into the etiology of azospermia in order to distinguish obstructive from non-obstructive azospermia. Low volume azospermia with a normal FSH and normal volume testes would be suggestive of obstruction. And certainly on physical exam, if the vasa were not palpable, that would clinch a diagnosis of congenital bilateral absence of the vasa deferentia. In contrast, normal volume azospermia with an elevated FSH higher than 7.6 and hypotrophic testes is pathognomonic for non-obstructive azospermia. Karyotype and Y chromosome microdeletion analysis should be recommended for men with primary infertility and azospermia or severe oligospermia with elevated FSH or testicular atrophy, or a presumed diagnosis of impaired sperm production as the cause of azospermia. The most common known genetic cause of male factor infertility is Klinefelter syndrome, the presence of at least one extra X chromosome. Although men with non-mosaic Klinefelter syndrome rarely have sperm in the ejaculate, they are candidates for microdissection testicular sperm extraction, as Dr. Schlegel will discuss shortly. A Y chromosome microdeletion is the second most common known genetic cause of male infertility. 3 specific regions are assayed on the Y chromosome, AZF-A, B, and C. These test results have both treatment and counseling implications for patients. Those men with complete deletions in the AZF-A or AZF-B regions are not candidates for surgical sperm extraction attempts and should be counseled regarding alternative methods of family building. Men who have AZF-C deletions are surgical sperm extraction candidates, and surgical sperm retrieval rates are roughly 50%, but they should be informed that any male offspring they conceive using their sperm will also have fertility issues. Next slide, please. The guideline does provide a quick reference algorithm for evaluation of the infertile male. And a section of this algorithm, as shown here, includes an outline to approach the evaluation of the azospermic male, as we've been discussing. And this really emphasizes that initial differentiation of obstructive azospermia versus non-obstructive azospermia should begin at the level of interpreting ejaculatory volume on the semen analysis, FSH, and physical exam findings. Next slide. Continuing on with evaluation for azospermia, clinicians should recommend Cftr mutation carrier testing, including assessment of the 5T allele in men with vasoagenesis or idiopathic obstructive azospermia. A vast majority, 80% of men with CBAVD have Cftr mutations, but roughly 20% of men with congenital unilateral absence of the vas deferens or idiopathic obstruction are also found to have mutations. Now, the mutations that cause obstructive azospermia may be different than those that cause clinical cystic fibrosis, and mutation frequencies differ based on a patient's race and ethnicity. So expanded carrier screening or gene sequencing should be considered, including poly-T testing on intron 8 to assess for variants. For those men who do harbor a Cftr mutation, genetic evaluation of the female partner should be recommended. Formal genetic counseling should be offered for discussion of carrier status as well. Sperm DNA fragmentation analysis is not recommended in the initial evaluation of the infertile couple. However, because elevated sperm DNA fragmentation may be associated with poorer ART outcomes and higher rates of miscarriage, sperm DNA fragmentation testing may be of value in the setting of either of these clinical scenarios, as previously mentioned. In the setting of repeated IVF failure and high sperm DNA fragmentation, one may consider using surgically retrieved sperm, although this approach is still controversial due to limited published data. For couples with recurrent pregnancy loss, men should be evaluated with karyotype and sperm DNA fragmentation. Circle back now to this formal recommendation that I alluded to during the initial rationale for assessment. In the unfortunate circumstance of recurrent miscarriages, thinking about male factor is important even in the setting of a normal semen analysis. Karyotyping may reveal unbalanced or Robertsonian translocations that may be associated with recurrent loss. High levels of sperm DNA fragmentation are associated with recurrent loss. A meta-analysis of 13 studies demonstrated that male partners of women with recurrent pregnancy loss have a significantly higher rate of sperm DNA fragmentation as compared with partners of fertile women. Sperm aneuploidy testing may also be considered in men whose partners have recurrent pregnancy loss and men with normal karyotype, although access to this test may be of limited availability in many centers. Next slide, please. Men with increased round cells on semen analysis should be evaluated further to differentiate white blood cells, which is pyospermia, from germ cells or immature sperm cells. In order to differentiate between these two, special staining by the lab is required. Although there is no evidence that high numbers of germ cells in the ejaculate impair fertility, patients with pyospermia should be evaluated for the presence of infection. For example, if culture testing is suggestive of prostatitis, antibiotic administration would be warranted. Anti-sperm antibody testing should not be done in the initial evaluation of male infertility. Anti-sperm antibodies may develop in the context of any event that disrupts the blood-testis barriers, such as trauma, surgery, infection. Because the presence of anti-sperm antibodies can impair penetration of the oocyte by the sperm, ICSI circumvents this issue. So anti-sperm antibody testing should be considered only if it impacts clinical next steps for a couple's treatment approach. Diagnostic testicular biopsy should not routinely be performed to differentiate between obstructive azospermia and non-obstructive azospermia. When discussing the appropriate diagnostic testing for azospermia, I've really tried to emphasize that importance of ejaculatory volume, FSH, and exam findings in guiding next step testing. In the rare circumstance when diagnostic biopsy is performed, the surgeon and lab should be prepared for sperm cryopreservation should sperm be identified in that biopsy sample so that it may be used for future ARTs if desired. Next slide, please. These imaging-related guidelines are primarily geared toward the reproductive urologists in the audience today. Neither scrotal ultrasound nor transrectal ultrasound should be performed as a routine part of the initial evaluation. In those patients with a tight scrotal exam or difficult anatomy, a scrotal ultrasound may be useful to assess for varicocele, in which case this would be identified in the presence of multiple veins with diameters larger than 3 millimeters and reversal of flow documented with Valsalva maneuver. Clinicians should recommend transrectal ultrasound in men with a semen analysis suggestive of ejaculatory duct obstruction. So this would be a low volume azospermic acidic semen analysis. Laboratory findings would include a normal serum testosterone, and physical exam would identify palpable vasodeferentia and normal sized testes. Clinicians should not routinely perform abdominal imaging for the sole indication of an isolated small or moderate right varicocele. This statement is really a frame shift from previous dogma. The vast majority of varicoceles are on the left side. And historically, the teaching was to pursue retroperitoneal imaging in the setting of any isolated right varicocele based on case reports that suggested that isolated right varicoceles may be associated with tumors. A retrospective study of more than 4,000 men with varicoceles showed no difference in cancer diagnosis based on varicocele laterality. However, abdominal imaging should be considered in the setting of new or acute onset or non-reducible varicocele, regardless of laterality, or in the setting of a large isolated right varicocele. Clinicians should recommend renal ultrasound for patients with vasoagenesis to evaluate for renal abnormalities. Embryologically speaking, the male genital tract is derived from the Wolffian or mesonephric ducts. The mesonephros is the precursor to the metanephros, the primitive kidney. Thus, Wolffian duct abnormalities are associated with renal abnormalities. For those men with unilateral absence of the vas deferens, up to 75% will have ipsilateral renal agenesis. For men with vasoagenesis, whether it's unilateral or bilateral, and regardless of Cftr mutation status, abdominal imaging should be offered. Next slide, please. Thank you for your attention to the statements related to evaluation, and Dr. Schlegel will continue on to discuss therapeutic options.
Thanks, Cori. Evaluation was beautifully summarized. Let's move on, and we're going to start talking about nonspecific therapy. In many cases, nonspecific therapy has been attempted to stimulate the testis using hormonal means, with a recognition that high intratesticular testosterone is important for spermatogenesis. Therefore, driving the pituitary to increase LH and FSH production may result in an increase in stimulation to the testis itself. In many cases, that is a recognition that testosterone by the male is both detected as testosterone levels as well as estradiol levels. In fact, the pituitary is much more sensitive to estradiol levels than it is to testosterone alone. Concept that impaired sperm production may be associated with low circulating testosterone, and therefore stimulating testosterone production would increase intratesticular testosterone production, is part of the basis for treatment in a non-specific fashion. Next slide. The agents used, of course, are off-label, including clomiphene, anastrozole, and HCG or FSH to stimulate the testis. Next slide. So I'm going to talk about several different areas of non-specific therapy. Antioxidants were originally supported by a Cochrane meta-analysis to increase the chance of natural pregnancy occurring for infertile couples. Unfortunately, the data to support this was relatively sparse, and in fact, the number of events that occurred, pregnancies that occurred, was less than 20 in that original meta-analysis. There also, after the closure of our data collection, was the Moxie Trial, which was a reproductive medicine network trial to provide an antioxidant to men in infertile couples as an attempt to both increase sperm production as well as decrease sperm DNA fragmentation. Although in some ways that trial was flawed, it was a negative trial that did not demonstrate benefit of antioxidants. Therefore, guideline statement number 43 basically is that the use of antioxidants to improve male fertility is not supported by data at this time. That doesn't mean that there aren't any oxidants that could potentially help male fertility. We just have not defined and demonstrated with data that there is benefit to use of antioxidants. In the area of the use of clomiphene or other selective estrogen receptor modulators, there are dozens of studies that have looked at use in the setting where men have a normal testosterone, and therefore this is a non-specific therapy for presumed idiopathic male infertility. And although a statistical benefit has been demonstrated, that benefit is quite limited. Pooling together the studies, as Chua did in a systematic review, you see an 18% clinical pregnancy rate after the use of clomiphene or other SERMs versus a 9% clinical pregnancy rate in those men who are treated with a placebo or not treated. Taken together, that is a quantifiable benefit, but the guideline statement number 42 takes into account both the benefit and also the alternatives to treatment by stating that clomiphene or other SERMs have limited benefits that are far less than what would be expected for assisted reproductive technologies. Similarly, exogenous FSH therapy has been used and surveyed in several different reviews. The most recent review in 2015 looked at 15 controlled trials and a number of studies using both recombinant FSH as well as purified FSH. And again, there is statistical benefit. Pregnancy rate of 10% in the treated men versus 1.5% in the untreated men. Taken together, that is a relatively small benefit, and given particularly the cost of FSH therapy for male infertility, which typically is given for 3 months or longer in those trials, one must consider that there's a potential to benefit, but this is not a likely routine intervention that we are going to offer for men with idiopathic male infertility. Next slide. In terms of varicocele, the data are a lot cleaner. Next slide. So The guideline statement number 25 is that surgical varicocelectomy should be considered in men attempting to conceive who have palpable varicoceles, infertility, and abnormal semen parameters, except for Azospermic men. This offering of varicocelectomy takes into account the concept that the female in this partner has either normal fertility or potentially correctable infertility. It emphasizes the fact that repair of palpable, larger varicoceles is what's most important. It gets back to the concept of what Dr. Tanrikut said before about the use of ultrasound not to be used as an approach to find very small or clinically insignificant varicoceles, but to emphasize the larger palpable varicoceles. The absence of definitive data for Azospermic men does not mean that there is no potential benefit of varicocele repair for men with non-obstructive azospermia. Merely it addresses the fact that there are no controlled trials that compare varicocele repair for men with non-obstructive azospermia versus no repair. And therefore, there's an absence of definitive data. Next slide, please. This is just part of the Cochrane analysis, which again focuses on men who have clinical varicoceles, infertility, and abnormal semen parameters, and demonstrates a marked benefit of varicocele repair in terms of allowing initiation of pregnancies for those couples. Next slide. Several general considerations are included as well. Next slide. As stated before, testosterone monotherapy is contraindicated for men interested in fertility, either present or future. It also recognizes that men with low testosterone can be therapeutically treated. This is not non-specific treatment. This is specific treatment for men who have documented low serum testosterone, discussed in the guideline as total testosterone, using either SERMs, aromatase inhibitors, or HCG injections. In terms of hormonal treatment, we also pulled out men who have hyperprolactinemia, emphasized that they should be evaluated for etiology and treated accordingly. So, for example, men who have hyperprolactinemia that may be related to medications may be most effectively treated by stopping those medications and reevaluating them. Similarly, men with hypogonadotropic hypogonadism should be treated based on etiology, implying that they would be evaluated for the etiology and then specifically treated. Next slide, please. In terms of intervention with assisted reproduction, either IUI or IVF, guideline statement 37 is that men with low total motile sperm count on repeated semen analysis should be informed that IUI success rates are low and treatment with assisted reproductive technology should be considered. Now you will notice in here that there is no absolute cut point because the data didn't suggest an individual cut point like 5 million motile sperm per ejaculate was really the critical level. There's a wide heterogeneity of studies looking at success of IUI for male factor. Similarly, we thought it was helpful to include the concept that male infertility may be successfully treated with assisted reproductive technologies. Next slide. We also looked at chemotherapy and came up with some statements based on the existing data. Next slide. Clinicians should discuss the effects of gonadotoxic therapies and other cancer treatments on sperm production prior to commencement of therapy. This is a relatively obvious clinical principle. Similarly, clinicians should encourage men to bank sperm preferably in multiple samples prior to commencement of gonadotoxic therapy or other treatment, including surgery that may affect the male reproductive tract. Based on existing data, we had a guideline statement number 49 that semen analysis should be performed 12 to 24 months after cessation of gonadotoxic therapy, because that's typically the first stage of recovery. And similarly, based on existing data, that couples should avoid conception for at least 12 months after chemotherapy and radiation because of the increase in sperm aneuploidy that's present and the suggestion of an increased risk of birth defects. Next slide. Similarly, clinicians should inform patients undergoing retroperitoneal lymph node dissection of the risk of aspermia, and clinicians should obtain a post-orgasmic urinalysis for men with aspermia after retroperitoneal lymph node dissection who are interested in fertility. Finally, clinicians should inform men seeking paternity who are persistently azospermic after gonadotoxic therapies that testicular sperm extraction is a treatment option, and that was guideline statement 52. Next slide. In terms of azospermia treatment, next slide. Post-vasectomy, reconstruction, sperm retrieval, or both are viable options for treatment of couples where they are interested in fertility post-vasectomy. Similarly, microsurgical reconstruction is effective for both vasal and epididymal obstruction, and ejaculatory duct obstruction may be treated with sperm retrieval or ejaculatory duct resection. Next slide. Surgical sperm retrieval may be fresh or frozen. Data were inadequate to strongly push for one approach or the other. Obstructed men may have sperm taken from the testis or epididymis, and aspermic men may have sperm obtained by sperm retrieval or induced ejaculation, including oral sympathomimetics, alkalinization of urine with or without catheterization, electroejaculation, or penile vibratory stimulation. Similar approaches can be used for retrograde ejaculation. For men with non-obstructive azospermia, the existing data suggests that microtesy should be performed, both because of its increased efficacy and lower risk of side effects. Next slide. Some additional treatment considerations for non-obstructive azospermia. Patients with non-obstructive azospermia should be informed of the limited data supporting pharmacologic manipulation with SERMs, aromatase inhibitors, and gonadotropins prior to surgical intervention. And this had a evidence level of grade C because of the very few studies that have been done to compare placebo to intervention or just repeat surgery in the case of men with non-obstructive azospermia. Similarly, for men with clinical varicoceles and non-obstructive azospermia, couples should be informed of the absence of definitive evidence supporting varicocele repair prior to ART. This was an expert opinion, again, based on the lack of comparative studies. Next slide. So in summary, I think we can see that management of many male factors are effective. Non-specific treatments are of relatively limited value for male infertility. Male contributions to reproduction are increasingly being identified. Chemotherapy and radiation and its teratogenic effects on sperm, I think, have been quantified for the first time in recommendations in a guideline. And treatment of the most severe male infertility cases are still often possible with sperm retrieval and IVF, or in the cases of obstruction with microsurgical reconstruction. Let Matt take things over now. Next slide.
All right, we have some questions that have come through the chat here, so thank you everyone for participating. The first question is, do the recommendations in the lifestyle and general health section apply to men who may be interested in semen analysis outside of infertility testing? For example, the proliferation of at-home or mail-in semen tests, which may identify individuals with abnormal semen parameters. Should those individuals be counseled on health risks and the adverse health outcomes based on advanced paternal age? What do you think, Dr. Tanrikut?
Well, the guidelines didn't include the at-home tests in particular. With respect to lifestyle recommendations and changes, the quality of evidence was relatively low in terms of looking at associations or improvements that could be made. That being said, certainly that won't hurt sperm production or sperm quality. So I think for any patient considering family building efforts, whether he's gotten to that point of having a formal semen analysis in a lab or is considering doing a semen analysis at home, it's a discussion that can happen early on. I sort of missed the question that was thrown in there about advanced paternal age. Could you repeat that, please? That was a little bit different than the lifestyle component.
Let's see there. She said, should those individuals be counseled on health risks and the adverse health outcomes based on advanced paternal age?
Yes, I think that's a separate issue from semen analyses themselves. I mean, that's the counseling component that I think is important, that actually can begin in the general OBGYN's office or in the RE's office, or at the point when the couple comes in to see us, or if the male partner comes to see us on his own. So just based on age, I think those conversations are important to initiate.
And I think it's, critically incumbent upon us. Not all of the REIs are actually seeing the male partners, or perhaps not even considering their ages. And I do think it falls to male reproductive experts, particularly urologists in many cases, to have that counseling that Cori talked about.
Yeah, certainly that age range, I mean, greater than 40, that's so many of our patients. It's not as though we're talking about men who are in their mid-60s or something like that. So very relevant.
Thanks, great answer. All right, so I want to go back to guideline 3. So men with one or more abnormal semen parameters or presumed male infertility should be evaluated by a male reproductive expert for complete history and physical exam, as well as other directed tests. So this may be the most practice-changing guideline statement. So as many of us recognize, the majority of men with an abnormal SA are not currently referred for evaluation in lieu of ART. So what would you say to our colleagues who may not have good access to a male reproductive specialist, and what should we do as a specialty to provide greater access to care for our patients?
Well, I think in terms of guidance for our colleagues, this document is clearly an important document to give guidance for an initial evaluation. I think with the forced rapid adoption of telemedicine that the pandemic has brought upon us, those of us who are very specialized reproductive urologists have been able to cast a wider net and be able to reach patients who aren't in our immediate geographic area. So that's been a positive that's come out of all of this. And I think that will probably continue in the future, or certainly I hope that will continue in the future once we get beyond the pandemic, this capability of using telemedicine, at least for the initial evaluation, history obtaining, counseling, and guiding from afar the testing that needs to be done.
Dr. Schlegel, a question has come in about varicocele repair. Can you please clarify the lack of sufficient data for varicocele repair in men with non-obstructive azospermia, and when might you still consider it?
Sure. So I think this is a difficult area because the data do not exist. So most of the published literature refers to men who have non-obstructive azospermia, clinical varicoceles, and undergo varicocele repair. In those studies, there are no comparators. And we certainly know that some men who are documented as having azospermia previously will have rare sperm seen in the ejaculate without any other intervention. And that is why we critically need controls to quantify the benefit of varicocele repair. Do I suspect that some couples benefit? Yes. What the proportion of couples that will benefit, and is it worth having them delay ART and sperm retrieval for 6 months to get that benefit? I think we need to do better at putting data together that demonstrate who that is and who that's going to be. Personally, I look a little differently at a younger couple, particularly with men who have a large varicocele, than couples who are older of non-obstructive azospermia, because that 6 month or more time element may be more critical for the older couples.
There have been a few questions that have come in about advanced maternal age with the cutoff at 40, and this being just such a large percentage of our patients. Dr. Tanrikut, how do you counsel these patients? Is there any do you have any tips for what you say, or which of the more common health concerns do you specifically counsel on patients? If you know, 43-year-old patient with idiopathic infertility, what would you say to that patient?
Sure, it's a good question, and I think it's a complex question that we don't have defined answers for at this point in time. And when I do bring it up to patients, many are surprised. You know, I think they're well versed or have learned, at least by the time they've come to us, that female partner age is a big predictive factor in terms of their fertility outcome. And so the discussion about advanced paternal age and that a man who's 43 may qualify as having advanced paternal age is a shock to many of them. Because it's not something about which we can take action, we can't turn back the time, it's really more about discussing the counseling component of things and talking about the increased risk for primarily the genetic related abnormalities. I would add that also I have had a subset of patients coming in who have learned or heard about this in their 30s, expressing an interest in banking sperm, or men who are now in their 40s who, for whatever reason, had banked sperm in their 30s and are planning to build a family with their current partner and trying to ascertain if they should use their 40-something-year-old sperm or their previously frozen 30-something-year-old sperm. So I think we have a lot more to learn about this, but it begins with a dialogue with the patient to educate them about it.
One of the things that I think the committee was very struck by is, even though as men get older, there's an accumulation of these genetic defects within sperm, that was clearly measurable back to age 40, and that's why the number 40 came in there. So it's not that you drop off the cliff at 40, but that's clearly an age at which you can measure some of these effects.
I'm going to keep moving here. A lot of questions are coming in, so we're going to jump around here. This one comes in regarding the lack of evidence regarding hormonal manipulation prior to surgical sperm retrieval. Does that also apply to men with significant notable hypogonadism with a testosterone less than 200? This person asks or says he believes many of us have anecdotally noted a benefit of men with significant hypogonadism and NOA with hormone manipulation prior to sperm retrieval. Could you comment on that, Dr. Schlegel?
Yeah, so it's very important to separate out those men with idiopathic normal testosterone and the use of SERMs or other medical therapies versus men with low testosterone. For men with low testosterone, that is a medical intervention with a clear indication. And again, there's a separate statement that recommends treatment for men with low testosterone. The data to support treatment of NOA with normality is not at the same level.
All right, Dr. Tanrikut, this question has come up a couple of times, a version of this. Could you comment on the management of recurrent pregnancy loss for men with high DNA fragmentation, or testing fragmentation in these men in couples with RPL?
So the testing, of course, as mentioned in the guidelines, would include a karyotype and the sperm DNA fragmentation assessment, as you've indicated. And Varicoceles have been associated with a higher sperm DNA fragmentation. So of course, as part of the complete evaluation, they need a physical exam. With respect to next step considerations, certainly I think many couples would be directed down the path of PGTA as a consideration for addressing that issue with respect to recurrent pregnancy loss. Dr. Schlegel, do you have other thoughts in that regard?
Well, and I think, once you identify abnormal sperm DNA fragmentation, looking for specific causes, whether it's infection or prolonged abstinence or other factors, is also a key component of it. And that's part of the dialogue and history that you're taking from those couples.
Dr. Schlegel, can you talk a little bit more about the lack of data on the use of antioxidants? This person says it's a common practice and recommendations by many REIs and urologists who are evaluating male fertility patients include the use of antioxidants.
Sure. Well, I wouldn't be surprised if there is some combination of antioxidants that is beneficial for male infertility. What we don't have at this point is we don't have a clear indication of what agents to use in what dose and for which patients. For example, some have suggested those with increased seminal reactive oxygen species may be good candidates for treatment. It's hard for me to believe that sperm, which are so sensitive to oxidative effects, couldn't possibly be helped by any systemic therapy that includes antioxidants. We clearly have not found it, and even when the data are pooled together with different agents at different doses, we haven't been able to demonstrate that benefit. So we need better studies.
Dr. Tanrikut, so what interventions would you advise for men with fertility problems with a higher than average BMI?
So the data were lower quality data in this regard for lifestyle, but obesity was associated with poor semen parameters, and poor diet was also associated with poor semen parameters. So to encourage, generally speaking, a heart-healthy diet and careful moderate weight loss, not a brisk weight loss, may improve semen parameters, but again, low quality data. I think that's an area that's ripe for further stringent research.
Here's a good question. What investigations are recommended for isolated teratospermia, isolated low morphology? Comes up a lot in the REI practice, I believe.
So the guideline did not specifically address that. And I think, an expert opinion by some is that you need to take into account isolated teratospermia together with sperm concentration, because morphology is reported as a percent abnormal, and that's a percent abnormal of the total concentration or total count of sperm that are present. So again, I think that's got to be nuanced to the individual clinical situation, except for specific abnormalities of teratospermia like globospermia.
Dr. Tanrikut, so guideline 21, scrotal ultrasound should not be performed in the initial evaluation of the infertile males. So in the era of COVID, scrotal ultrasound has been more commonly used in male reproductive specialist practices, particularly for telemedicine and patients that live far away or can't have an exam. So now the guidelines recommend a more thorough evaluation of the male with abnormal semen parameters, and especially in the post-COVID era, could an REI with limited access to male reproductive specialists consider scrotal ultrasound to rule out major pathologies like varicoceles or testis atrophy?
Very timely question. Remember, the guideline is it's not indicated for the initial evaluation of the infertile male. Certainly, if one were considering using a scrotal ultrasound to assess a patient in the manner in which you've described, it should not be the sole assessment of the patient. So because you don't radiographically identify a testis mass or a sonographically identified varicocele doesn't mean that everything else is thrown out. So I think the counseling component is very important. keeping in mind that holistic approach of other issues that may be going on from a medical perspective for a patient are important. But certainly it could be used as an adjunct, particularly together with telemedicine if there are the distance issues or access issues to the office. If you have a high threshold of suspicion that someone has a varicocele, that may be helpful. I think really the biggest challenge is either trying to ensure that this study is performed by a facility that knows what you're looking for with a varicocele, or directing the center where you send the patient to perform the ultrasound appropriately. So you want to get measurements of the testes in order to assess testicular volumes. You want to get venous diameters of the veins, both at rest and with Valsalva, and color flow Doppler needs to be used to assess for reversal of flow with Valsalva. Otherwise, you can't interpret the test appropriately.
Thanks. All right, so this will be the final question for Dr. Schlegel. So this is regarding Guideline 44 for men with idiopathic infertility. A clinician may consider treatment with FSH analog with the aim of improving sperm concentration, pregnancy rate, and live birth rate. So there's clearly a strong role for this treatment in hypogonadotropic men, but for men with idiopathic infertility and normal FSH levels, where do you see the role for this treatment, since there's not really a lack of spermatogenic signaling by the pituitary gland, and taking into account the cost of the treatment being so high? And then do you have any experience with this that you could share?
Sure. So the data are quite strong that FSH has small but real benefits for these men who have idiopathic infertility. It increases semen parameters. It will increase natural pregnancy rates. Its effects on IVF outcomes are a little bit less clear. But again, that has to be tailored together with the incredible cost of such a treatment and the relatively small delta. It was only about an 8.5% difference in pregnancy rates for the men who received FSH, either recombinant or purified, versus placebo. And so from a practical standpoint, I think all of us were impressed to see that that data exists and it is solid. But from a practical standpoint, I rarely use that because of the incredible cost plus the time period that's required to get that benefit and the overall very low pregnancy rates.
Thank you so much to both of you. There are a number of comments that have come in, all thanking you for the excellent presentation tonight. So with that, I'll turn things over to Sarah for some final remarks. But thank you to Dr. Tanrikut, Dr. Schlegel, for these excellent presentations, for your hard work on this guideline, which turned out to be such a gem for all of us in the field. And so Sarah has a few comments to close things out. So thanks, everyone.
Thank you, everyone, for joining our session. Thank you, Dr. Coward, for moderating a fantastic session. To our panelists and attendees, thank you. You will receive a survey after this session, and your feedback helps us give you the most relevant content, and your input is appreciated. This session was recorded and will be available on our website in the near future. Please watch your email for notification about future webinars. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.